Hi everyone, welcome to Nursing 548 in our first video of the semester. I enjoyed meeting with all of you yesterday and I thought we had some great information on chest x-rays, and let's learn a little bit more about respiratory problems. In this video you're going to see me cutting back and forth to different web links of some resources that I found that I think you might be interested in. I will provide a document that has those web addresses if you want to pursue that further. So in the United States, more Americans seek medical treatment for a cough than any other complaint, and it costs in excess of $1 billion annually to treat these symptoms. So by deduction, you're going to see probably quite a few individuals come in at different times during the year complaining of respiratory problems. Some of the common complaints that patients have are cough, shortness of air, and bringing up blood in their sputum. So for any patient that comes in, we need to start thinking about our differential diagnosis. Like Dr. Brandstetter commented on yesterday, you are working on your differential diagnosis as you're asking questions when you're first seeing the patient, such as when did the cough start? When does it occur? Is it morning or is it nighttime? Is it in the heat? Is it in the cold? Is it with exercise? What stimulates it? What aggravates it? What may alleviate it? Describe the quality of the cough. Is it a wet cough, dry cough? Is it productive, non-productive? And are there any associated symptoms seen with it? In practice, there are some cough preparations that are beneficial to the patient for a variety of reasons. The first one mentioned here is dextromethorphan, or the pseudoephedrine bromide dextromethorphan that can be given every 3 to 4 hours as needed. This is a cough suppressant. The next are your benzonates, and this falls in the antitussive category, and pharmacology wise this anesthetizes the respiratory passages to help reduce the cough reflux. In the short term, there are some medications that are beneficial and may or may not require a green script. Your codeine can be used as a short term. You may also see Phenergan cough medicine in elixir form to help with cough. There's also your Tussinex, which is an extended release suspension, and since it's a hydrocodone base, it will require a green script. Also, you have your decongestants, your antihistamines, your intranasal steroid sprays, and expectorants, and with those it's very important that you have increased water. Otherwise, the drainage that may be causing the cough is going to become thicker, but increased water intake helps all of your drainages to be a little loose. The underlying cause of the cough may be able to be quickly determined by your history and physical, but it may be necessary to consider some other testing. So some diagnostic testing that you may consider is spirometry, chest x-ray, or a CT scan. Just as a refresher, spirometry is that measurement of air in and out of the lungs, and that data that it provides helps distinguish between respiratory conditions. In our Blackboard site there is a tab for the lecture, and underneath that there are a couple of PDFs, and there is I believe it's the first one that talks about values and summaries that you might find beneficial for clinical, and go to page 10 and look at that. I believe that it'll give you some more information. There's also more information there on peak expiratory levels for different ages based on gender that will help you with your diagnostic process. Other diagnostic tests include chest x-rays, which can show more about infection, pneumothorax, cancers, as well as other chronic lung conditions such as emphysema and cystic fibrosis. CT scans are going to scan the chest and are able to detect smaller areas of concern such as lung nodules, if there was issues with the pleura or any parenchymal disease. They are also going to be able to tell more about lymph nodes and any other solid non-vascular structures. So let's talk about dyspnea, which is shortness of air, and it's the perceived perception of difficulty breathing or the inability to get air in and out. When you have the patient that presents with shortness of air, you need to consider differential diagnoses from several body systems, such as pulmonary, and that could be related to COPD, asthma, some pulmonary hypertension, or some exogenous factors such as massive obesity, ascites, or pleural effusions. Considering cardiac factors could be congestive heart failure, mitral stenosis, mitral regurgitation. There can be hematological factors such as chronic anemia. When your red cells are low and they can't carry oxygen, then of course you're going to have some shortness of air. And then psychiatric considerations may include anxiety or panic attacks. So your diagnostic tests are going to be determined by your history and physical exam and what your expected causes of the shortness of air might include. And these can include a chest x-ray, which would be useful to rule out tumors. It can give more information on TB or pneumonia. And as we talked about yesterday in class, some insurances require that you begin with a chest x-ray before you move forward to for any other type of imaging. A CBC will offer more information on an anemia or any infections. Your pulse ox, of course, is going to tell you what your saturation level is. If you have one that's less than 90%, then it's important to do some ABGs to get a better assessment of that saturation level. If there's any concerns for carbon monoxide poisoning, you're going to want to check a carboxyhemoglobin level. Note though that heavy smokers can already have some predisposition to having some carbon monoxide in their blood and can range anywhere from 4 to 15%. If your patient is noted to have a level greater than 20%, that may be causing some shortness of air and some headaches, and then greater than 40% may lead to seizures and death. And we talked a little bit about spirometry. And then the last test that you may consider is diffusion capacity, which is used for interstitial lung disease. Your initial treatment is to always help the patient find relief and then determine what underlying causes and factors may be causing the shortness of air. Sorry, I don't think I moved forward on that slide. So there are the diagnostic tests that we just previously talked about. For hemoptysis, just to review, that's the expectoration of blood. It may be bright red, and this could indicate new bleeding, or it may be dark, and that could be indicative of old bleeding, and it also can have clots. And what's one of the most important things is to determine if you're in an emergent or a non-emergent situation, and then that will determine if you have the time to do some testing then, or if you need to just get vital signs and send them on with EMS to the ER. If you do have time, then getting a CBC, a chest x-ray, and a sputum culture are going to be beneficial in working this problem up. 80% of all hemoptysis come from inflammatory causes, such as bronchitis, bronchiectasis, which is damage to the airway and difficulty in clearing mucus, can come from pneumonia or from TB. Our patients may say that they've coughed up blood, and it may be blood-tinged or blood-streaked sputum. So when you're doing your cultures, be sure and send that down for AFB for your acid-fast bacilla for if you're trying to rule out TB. It will also give more information on if you have a pneumonia or abscess by getting a culture and sensitivity. It's also important if you have hemoptysis to assess if your patient is on any blood thinners, as this may be causing some of that streaking or blood-tinged sputum. If the patient is having massive hemoptysis, then likely they're going to be heading to surgery or for bronchoscopy. And then for non-emergent causes, it's important to find out what that cause is and how you're going to treat. Patient education is very important, as the patient needs to know what might have precipitated the hemoptysis and best ways to prevent. Let's talk for the next little bit about some upper respiratory infections. And so bacterial infections make up about 25% of URIs. We have the flu, the common cold, acute laryngitis, acute epiglottitis, and then RSV. With upper respiratory infections, it's important to get that detailed history of the physical illness. Your physical findings may not be overly significant, but you're going to want to, depending on what you find, if you had concerns of the throat, run a rapid strep test. You may want to do a flu nasal swab. You may want to do a CBC to indicate if we have any infections in the white count, and then also do a culture. Management of the upper respiratory infection is going to be based on what your diagnosis is. So you're going to have conversations with the patient about an antibiotic or an antiviral. In the links I'm going to provide, there's a document on how to talk with patients, parents, about not treating with antibiotics and having sometimes those difficult conversations. We all know that patients and families want to go out with something that's going to make them feel better, but often antibiotics are not what is needed. So I think it's important to have a plan, if you're not sending a patient home with antibiotics, of what the plan is and how you're going to treat the virus. And then also providing written instructions of over-the-counter medications that will help the patient manage those symptoms that they are having. If you're able to meet those needs, I think your patient or your family member of a little one is going to go out feeling more satisfied. They can also use cough suppressants over the counter. Rest is very important, increasing fluids and medications to help with any fevers. So the use of antivirals is important to start those within the first 48 hours to have those to be as effective as possible. We talked about symptom management. Associated with the flu are some secondary infections that may arise, one of those being pneumonia. You can also develop an acute sinusitis, otitis media, and bronchitis. So after the patient has been diagnosed, if fever continues or you've done a white blood cell count is greater than 12,000 or they have a productive cough, it's important that they get back in touch with you so that you're able to rule out some form of bacterial infection. With pneumonias, the pneumococcal pneumonia is the most common, but the staphylococcal pneumonia can be the most serious. So it's important to have your patients understand when they need to get back in touch with you. A viral pneumonia is least common, but it does have a high mortality rate with our pregnant ladies and any patient that may have a rheumatic heart disease. Let's talk next about some asthma. We know that asthma is a chronic inflammatory obstructive disease of the airway. There are three principal triggers that include allergens and environmental factors, and these can be inhaled substances, foods, or medications. Infections can be a trigger for asthma, and then also psychological factors such as stress. With asthma, you can have episodic symptoms of airflow obstruction. There can also be obstruction with diagnosing asthma. The obstruction must be at least partially reversible. The gold standard for diagnosing asthma is with a pulmonary function test with pre and post bronchodilators to demonstrate reversibility, and a 15% or greater increase in the FEV after 2 puffs of a beta adrenergic agonist is seen, then we can work towards the diagnosis of asthma. ABG analysis should be included in your initial workup, and also it's important to get a chest x-ray to see if there's any hyperinflation or thickening of the bronchial walls. And then a CBC is not that you're looking for infection, but if you look for the eosinophils, those are elevated with inflammatory concerns, and you may see an elevated eosinophil level with asthma. In the management of asthma, it's important to identify exacerbating features. Self-monitoring, whether it's by symptom or peak flow at home, is important. The patient needs to have written instructions on how to manage an acute attack and then what they need to do if there's an exacerbation. And then education and follow-up with spirometry at least every 1 to 2 years if the patient is controlled, and then visits every 6 months if controlled, and every 2 to 6 weeks if uncontrolled. We're not going to go into detail on this, but I would encourage you to look in the book for these different sections. There's a classification section which breaks asthma down into intermittent or persistent, and persistent being mild, moderate, or severe, and that's on page 351. There's also a stepwise approach to management of asthma and with medications. That's on page 353, and then further details on the medication are on 354 and 356. And then some expectations for your patient that has asthma you can find on page 357 on table 9.4. And then there's some risk factors for fatal asthma on table 9.1. And this talks about comorbidities, whether they've been in the hospital, illicit drug use, etc. So I encourage you to look at that section as well. So next, let's talk about COPD. We have lots of patients in the hospital. You know that you see for COPD, and that's when they've had an exacerbation or when they're in the hospital for something else. So you're going to be monitoring those patients in the outpatient setting quite a bit. And so we know that COPD is chronic obstructive pulmonary disease. And the obstructive component is impaired expiratory flow rate, and it can be reversible, such as with asthma, but there also can be irreversible COPD with chronic bronchitis and emphysema. Then another component is restrictive, and you may have reduced lung volumes with this form, and you may see this with musculoskeletal disorders, tumors, if the patient has had a lung resection, or if they have interstitial lung disease. Some known risk factors for COPD is based on age. Men are more susceptible to COPD than women. Those that smoke cigarettes, have reduced lung function, may have occupational exposure, and have been exposed to air pollution. There are two types of COPDers. The first one are the blue bloaters, and those are individuals that have chronic bronchitis and pulmonary hypertension. You may see that they have edema, cyanosis, and polycythemia. The second are your pink puffers. Those are individuals that have emphysema and have more severe shortness of air. They have relatively normal ABGs, and they may also be noted to have a barrel chest. Some objective findings that you will see will be the change in the chest diameter from a 1-to-1 perspective, whereas with a normal chest it's a 2-to-1. You may note distant breath sounds. There may be expiratory wheezes at the end of their respiration. You may note prolonged exhalation, neck vein distension, pedal and ankle edema. You may notice clubbing of the fingers and fatigue. Diagnostic tests include PFTs, chest x-rays, although those may be normal in early COPD, chest CTs, CBCs, sputums, EKGs, and ABGs if O2 sats are less than 90% or if your FEV is less than 50. Pharmacological therapy for COPD includes inhaled beta-2 agonist, bronchodilators, inhaled anticholinergic dilators, corticosteroids, your xanthines, which are your aminophylline and your theophylline. Antibiotics when needed, diuretics, mucolytics, and expectorants. So under Lecture 1 there are the GOLD guidelines, and those are for COPD. Your inhaled beta-2 bronchodilators are your first line of defense, and that's your rescue inhaler. And then your inhaled anticholinergic bronchodilators are used for maintenance. Your steroids will help with your anti-inflammatory. We talked about the xanthines as being aminophylline or theophylline, and these have a narrow therapeutic index, so if you are prescribing these, it's important that you monitor these closely with serum levels to make sure that they're in the proper therapeutic range. You will use diuretics if you have heart failure. Your expectorants and mucolytics, such as your guaifenesin, are not helpful in the COPD category. What is probably most helpful is having chest physiotherapy and making sure that your patient is well hydrated so that their secretions stay loose and easy to cough up. Patient education is important, and that includes smoking cessation, yearly influenza shots, and every 5-year Pneumovax, PT rehab if there's been deconditioning, support groups, teaching pursed-lipped breathing and oxygen therapy, assessing for depression, and if that is noted to treat, and then discussing advanced directives and what the patient's wishes are if something should happen and they are not able to they're having respiratory issues. Would they want to be put on the ventilator and have all measures taken? So those are some difficult discussions to have, but important discussions to have while your patient is able to have. We are getting ready to change to community-acquired pneumonia. I think this will be a good time to stop this video as we're almost at 20 minutes, and we'll pick up on the next one. See you soon.